So, good afternoon, everyone. It's my pleasure to be here this evening to discuss with you about one of the most intriguing and interesting part in the field of urology, which is actually the non-muscle invasive bladder cancer area, starting from the intermediate to high risk. And we will discuss in particular this evening with you what are the current landscape, but also what are the ongoing studies and what we are going to expect in the few next year. Because we actually do believe that the change is fielding, the field is a changing, and there is a lot to discuss, a lot to know, and many challenges will occur to all urologists to dealing with this disease. So today with me, we will have three great experts in the field. We have Dr. Francesco Soria, Dr. Laura Mertens, and Dr. Carmen Mir. And I would like to start to give space to Dr. Laura Mertens, who will present the intermediate risk non-muscle invasive bladder cancer definition and treatment paradigms. So Laura, thank you for being here, and the floor is yours.
So, ladies and gentlemen, we are going to discuss first intermediate risk NMIBC. As Marco said, a very interesting topic, and I think we could actually make a full webinar about intermediate risk NMIBC. Let's just first have a look at this image, because when we are discussing intermediate risk NMIBC, we have on the one hand progression, which is in fact a wolf that we fear, is rare, but it's very dangerous. And on the other hand, we have a rat, an annoying rat that we cannot get rid of. And the rat stands for recurrence. It's frequent, it's irritating, it's costly, and it will just keep on coming back. And in intermediate risk NMIBC, we need to decide whom to chase, with what, and how often. So that is intermediate risk NMIBC, and that's what we're going to discuss this evening. First, have a look at the broader picture, the bigger picture. It's important to realize that the molecular landscape of NMIBC is highly heterogeneous. And as this table shows, there are multiple gene expression signatures associated with distinct clinical features in NMIBC. For example, grade, stage. Some low-grade tumors carry relatively few mutations or specific mutations, while some high-grade NMIBCs share molecular traits more typical of muscle-invasive disease. And these biological differences translate into very different clinical outcomes. For example, if we look at grade, we know that low-grade tumors recur often, but progression is very rare. For high-grade NMIBC, both recurrence and progression are substantially higher. And this is only tumor grade. To capture this heterogeneity, the EU guidelines divide NMIBC into 4 risk groups: the low-risk group, intermediate risk group, the high-risk group, and the very high-risk group, based on grade, tumor stage, but also 3 clinical factors: so age over 70, tumor size, and multifocality. And this classification stems from Sylvester's landmark analysis of thousands of NMIBC patients, which laid the foundation for our recent EAU risk calculator. Patients were stratified according to the previously mentioned factors, resulting in 4 risk groups. 4 risk groups of progression. So a group with very low risk of progression, and a high risk and very high risk of progression. And sitting right in the middle here, the red line, is the intermediate risk group, with about 1% risk of progression at 1 year and 4% at 5 years. So still relatively low risk of progression, but between the low and the high risk. 2 important things to bear in mind is that this model is based on BCG naive, BCG untreated patients, and it quantifies progression risk, but does not say anything about the risk of recurrence. So who exactly belongs in this group? The guidelines say actually everyone that does not fit in the low risk or the high risk or very high risk group. But to be precise, these are patients with primary low-grade TA tumors with 2 or more risk factors. These are patients with recurrent low-grade TA tumors, so the recurrences. But these are also patients with high-grade TA tumors with fewer than 2 risk factors. So that's our intermediate risk group. And although it looks like the small box in the middle, almost half of all NMIBC patients fall into this category. So these are our everyday patients. But here is the issue. As you can see, this category includes both low-grade and high-grade tumors, even though, as we just discussed, grade is one of the strongest determinants of outcome. And that's where the debate starts. According to the EAU, according to Sylvester's robust data, TA high grade is classified as intermediate risk unless 2 or more risk factors are present. But American Association takes a stricter view, and the IBCG goes even further, moving all TA high-grade tumors straight into the high-risk category. And that's based on a study led by Kamat at MD Anderson, showing that the risk of progression in intermediate risk TA high-grade tumors was not statistically different from high-grade or very high-grade disease. And more importantly, the progression risk remained similar regardless of how many clinical factors were present, as long as the patients were adequately treated with BCG. So they actually say it's all about the grade. High grade is high risk. On the other hand, here's EAU's counterpoint, a study by Irene Beijert, Bas van Rijn, the guideline panel, where recurrence rates for TA grade 2 and grade 3 and T1 grade 3 were similar, but progression rates clearly differed. So the time to progression, as you can see here, was significantly longer for intermediate risk TA grade 3 tumors compared to high or very high risk TA grade 3 tumors. But it's important to realize that in this data set, only 40% of patients received BCG. So whichever way you look at it, I think it's important to realize that intermediate risk NMIBC is not just a box. It's not a tiny box of patients. It's a spectrum of disease, a spectrum that runs from the low-grade recurrent tumors, the small annoying rats, to the solitary high-grade lesions, so the aggressive wolves. And understanding where each patient lies on that spectrum is key to improving how we treat and how we follow them. I think in clinical practice, we also get a completely different feeling when we see this, a small occasional low-grade recurrence, compared to this, a young woman with a primary 4-centimeter high-grade tumor. And most of us would probably want to manage those two quite differently. So what do the guidelines say regarding treatments? The EAU 2025 guidelines say offer installations of chemotherapy. So after TURBT and a postoperative installation, offer chemotherapy. The optimal schedule is unknown. Or give 1 year of BCG. So that's BCG induction and maintenance, full dose for 1 year. BCG seems somewhat more effective, also more toxic. So this should always be a matter of shared decision-making with the patient. But as I said, 2025. How sustainable is this recommendation if we remind ourselves that intermediate risk actually represents a spectrum? Using the same risk factors that define the group, we can further stratify intermediate risk tumors. And those with the highest number of risk factors clearly have the greatest likelihood of recurrence and progression. Francesco Soria, who will do another talk later this webinar, recently validated this risk stratification across European cohorts in a study by the EAU Young Academic Urologists, showing that a significant variation exists even within the intermediate risk group. Some patients behave more low risk, others behave more high risk. And as a result, and this is not yet in the 2025 guideline, but we expect it to feature more prominently in the 2026 update. When an intermediate risk tumor is high grade, BCG may be the preferred treatment option, may be prioritized. So again, not all intermediate risk disease should be treated equally. Then surveillance, as I mentioned earlier, the greatest threat in intermediate risk NMIBC is not the wolf, is not progression, but it's recurrence, repeated surgeries, patient anxiety, lifelong cystoscopic surveillance, and especially in the low-grade TA tumors, the recurrences are common, but they are usually non-invasive and they rarely progress. And that opens the door for treatment de-intensification, focusing not just on disease control, but on quality of life. Several strategies are being studied. Office fulguration or laser ablation. Laser ablation is compared in a randomized trial with TURBT and can spare patients an operation and anesthesia. Also, active surveillance can be an option, allowing controlled observation, provided that we avoid overscoping, of course. And then chemoablation, as tested in the DABLACA 13 study, where patients with recurrence NMIBC received intravesical mitomycin 3 times a week for 2 weeks with a TURBT or biopsy, only if response was incomplete. These are viable options, but not for the high-grade types in the intermediate risk spectrum, but very much for the low-grade intermediate risk tumors. Then, how often should we follow up? According to the EAU guidelines, cystoscopy at 3 months, then every 6 months for 2 years, and annually thereafter. But here too, one size no longer seems to fit all. Work is ongoing to design personalized surveillance schedules, and this will most probably follow in the near future. And then finally, for years, intermediate risk patients were the forgotten middle in trials. That's now changing. There are multiple ongoing phase 2 and phase 3 trials explicitly dedicated to intermediate risk NMIBC, something that would have been unthinkable just a few years ago. And these include studies on drug-releasing devices, intravesical chemotherapy, gels, oncolytic viral therapy, trials that finally focus on the largest, most burdensome NMIBC population. Yes, the heterogeneity of the intermediate risk groups makes trial design challenging, especially if you want to include patients in both Europe and the US. But given the frequency of recurrence and its impact on patients' life, I think it's absolutely needed to also focus on this group. And then let's end with a simple framework. Intermediate risk is not insignificant. This is where nearly half of our patients live, so what matters a lot. Risks should be redefined. Classic tools tend to oversimplify. There is not much progression risk, but there's plenty of recurrence risk in intermediate risk NMIBC. We should balance the treatment options, chemotherapy versus BCG based on shared decision-making, but preferably BCG for high-grade disease. Individualized approaches are ahead, precision of intravesical therapy, biomarker-guided care. We have to be aware of the burden. Patients often need multiple TURBTs, and we need to look for safer and effective alternatives. And thankfully, clinical trials will provide change. New trials, new hope for this treatment group. So we need to tame both the wolf and the rat. That's the future of intermediate risk NMIBC. Thank you very much.
Thank you, Laura. Excellent presentation. And so I would like to give just a small reminder for the participant of the webinar that we will have at the end of the webinar 15 minutes question and answer. And you can use the chat to ask your question, and then we will reply in the chat, but also we will use your question to guide the discussion at the end. So I will now introduce Dr. Carmen Mir. She will present about high-risk non-muscle-invasive bladder cancer, definition and treatment option. Thank you, Carmen.
Thank you, Marco, for the introduction. Very happy to be here. I hope we can clarify the topic. I think Laura did a great job at introducing the differences and the problems that we have with all the subtypes of patients. So my role today is going to be to talk about high-risk non-muscle invasive bladder cancer definitions and treatment options. These are my potential conflicts of interest. So we know already non-muscle invasive bladder cancer represents approximately 75% of bladder cancer cases. A lot of risk factors that are well known for us, like aging, environmental exposure, smoking. And one of the major issues with bladder cancer is the cost. It's very expensive for society to have patients with bladder cancer and to follow them. That is one of the issues with bladder cancer concern. And so in terms of non-muscle invasive bladder cancer, approximately 45% of the patients are high risk. In a nutshell, high-risk patients are basically CIS patients and patients with high-grade T1 without CIS. I will get a little bit more in detail in the next slides. To take a number, approximately for high-risk disease, the progression rates at 5 years are around 10%, as you can see on the right. There are 3 clinical risk factors that we do take into consideration in order to classify our patients. Age is one of them. If they are older, that's worst. Multifocality, if they have several tumors, that's worst. And if it's a large tumor over 3 centimeters, that's definitely something to take into consideration as well. These probabilities of progression that you can see on the slide, these are taken from the EAU risk classification that Laura actually mentioned. And as you can see, depending on the year as that you follow, but approximately, as I said, is around 10% at 5 years progression for high-risk non-muscle invasive bladder cancer to progress to muscle invasive. There are several risk stratification systems that we have used so far. The most common validated is UROWebinar and EORTC. As you can see here, this is an application of some of the series that are out there, and then you reclassify them according to, for example, EORTC. If there is a recurrence or progression, seems like they are better in terms of predicting progression, as Laura mentioned. However, we can see that they are not perfect, and we still probably lack the molecular application or into all these models in order to better stratify our patients. That's why Laura was mentioning that intermediate is like I would say like a gray box is a spectrum of disease that probably it has a lot of molecular issues in between that are different amongst them. She already mentioned this as well. This is as she suggested from the paper from the EAU risk calculator that we have nowadays and that we are using since 2021 from Sylvester. These patients did not have BCG. That would be the standard of care. There was actually a raise from MD Anderson. They look at their series of patients, for example, having received the adequate BCG, like having received at least 5 doses of induction and 1 of maintenance. And what we see is that the progression rates, maybe they are between 6 and 10%. So if adequate BCG is applied, maybe the progression is a little bit less, but the number to keep in mind is between 6 and 10. Okay, so if you get into the high-risk definitions, we look through the 3 guidelines that we most commonly use nowadays. It would be the EAU, AUA, and NCCN. We can see some differences, but I'm trying to summarize my best in a nutshell. So basically, EAU, what it does subclassify high risk into a very high risk criteria that includes actually patients with high-grade T1 plus CIS, and one of the risk factors that I mentioned before. This is a little bit different since the progression rates in that subgroups are supposed to be much higher. So in basically what we see in high risk are patients with high-grade T1 and no CIS, any CIS that is outside of that category. And also what we see is patients with TA high grade and T1 low grade without CIS are more than 2 risk factors. If we go to the AUA classification, it is a little bit different because as you can see, and Laura also mentioned, high-grade TA less than 3 centimeters might be considered actually intermediate risk. So that's a little bit off. And when we look at NCCN, we see that it basically mirrors what AUA has established. There is no difference, and there is no very high risk classification in this case. Why there is that? Why do we talk about it? As we have mentioned, TAs have been classified in different ways. This is an example from MD Anderson. Also, Laura mentioned it. I think it's an interesting one because it takes a lot of patients having received the adequate BCG, and all the TAs were subclassified between intermediate risk, low grade, intermediate risk, high grade, and high risk, high grade. And what we see here is that what is more interesting to me is that the progression rates for patients with intermediate risk, high grade, and high risk, high grade are very similar. So they behave with similar progression rates. So it means they're probably very similar. So now that we know more or less what high risk means and what it implies with the progression rates, there are a few treatment options available. So intravesically, that what urologists were more used to, implies obviously BCG. You can have mitomycin C. You can use gemdosa. Say now I'm using it more and more in the US. It's quite common here. You can also use hypertension. And also radical cystectomy is an option. In terms of systemic treatments, we have a very recent option that has come along, and I will discuss it a little bit, that is immunotherapy in this setting. You know this very well. It's been very well established for patients with high-risk disease. The standard pathway is BCG, induction, and maintenance, because it has shown to reduce the risk of recurrence much more than if we don't know anything. So why is that? Because we have a trial actually from the 2000s, quite old, quite old, but very good one, that it randomized patients with high risk non-muscle invasive bladder cancer to receive BC induction plus maintenance versus no maintenance. And the patients were supposed to receive it up to 36 months of maintenance, which honestly is quite a lot. I have to say my case is difficult to reach. And the results, what it showed is basically reduction in the recurrence rates, somehow also in the progression rates, and a little bit on overall survival, but overall, what we have to remember is that recurrence rates are much less if we do maintenance, at least generally 1 year, even though the number of patients that reach up to 3 years in this trial is quite small. Why do we do BCG and not mitomycin? A lot of studies were done back in the 90s about trying to compare these two intravesical treatments. One is chemotherapy and the other one would be considered immunotherapy. So different mechanisms of action, but the concept all intravesical. This is like a meta-analysis of all these little studies that were done in the 90s. And what it shows is that basically, if you compare BCG and mitomycin, and if you do BCG maintenance, at least for a year, that actually shows superiority to mitomycin in reduction of recurrence, 27% risk reduction. Also somehow a little bit of advantage in progression rates. However, this is hard to measure because all these progression events in these trials are fully reported. So now we know clearly why we're doing BCG and not mitomycin. How long do we do for this? How about maintenance? I talked about the SWOG 8507. We know this trial very well, that we have to do maintenance, but also in Europe, we had another trial that looked at two concepts. One is the length of the maintenance, 1 versus 3 years, and the other one was the dose of the BCG. And what happened is that, as you can see here, this is just a summary table from the trial, is that very few patients, like 35%, we have it here on the right, 3 years. 35% of the patients actually reach the 3 years maintenance, which makes the results at 3 years sometimes difficult to follow. And the other thing that we see is that in intermediate risk, we could go actually for 1 year, and then for the high risk, they would advocate for going for the full dose in 3 years. These are the results, and that's the rationale to continue encouraging patients to go further than 1 year if possible. This is also what the EAU guidelines say. If you go for intermediate risk, you would go for 1 year. And if you are in the high risk category, you would try to consider 3 years because of the decrease in recurrence rates. How often do we do it? We also looked at that. The Nimbus trial recently published, maybe more recent, not as recent as it was, but a couple of 3 years ago. It looked at having the same pathway, but decreasing the number of BCG installations, going for what would be the standard pathways, 15 installations down to 9 BCG installations. So we would look at if there was the same amount of recurrences and if there were less symptomatic for patients, so more feasible for them to have the doses that are supposed to. What they found is that this is not like that. If we decrease the frequency of the BCG, there is an increase in the recurrence rate up to 27%. And also what they saw is that the quality of life in terms of symptoms and bothersome for the patient is not as bad, is not better than you would have expected. So now that we know how much and how long and how often we give it, what happens in real life? In real life, it happens that the adherence to the long-term treatments, as I said, is not as good. Only 50% of the patients either in Europe or US actually get the treatment they are supposed to get. The rates of radical cystectomy, as you can see, are around 10%. So this is a reason to encourage patients to go a little further on their treatments. Other treatments that are available, especially interesting in the BCG era, in the BCG where we don't have BCG, that we can have an alternative. I have to say, where I work, actually, there is one hospital where there's no way we can get BCG, so all the patients are getting gemdose. We only have retrospective data regarding gemdocetaxel, the sequential, and what we see, this is an example of a series. It's over 107 patients, retrospective analysis, 50% of them CIS, 50% papillary with T1. And what we see that is interesting and is important to remember is that the high-grade recurrence-free at 24 months, so 2 years is around 80%, 82%. And we also see that tolerance is much better than what patients would report in BCG. There is also a retrospective comparison of gemdose versus BCG. This is also an interesting series, a long-term, that it also includes all high-grade, high-risk patients. And if we look at the red square, that is what is interesting to me, just to compare a little bit 2 years to show 24 months, what we see is around 78% recurrence-free survival versus 62. It was around 80% on the first single series that I showed. So kind of similar, so around 20% at 2 years, which is not bad, I would say. What we're looking forward is to having prospective data on this setting, and that's what the BRIDGE trial will bring. The primary endpoint of this trial, it will be event-free survival, that, as you know, is a composite of events of recurrence, progression, and death. And I have to say, very looking forward to these results. One treatment option, as I mentioned, is radical cystectomy. As I showed before, it is around 10% of the treatments that are offered. We know that radical cystectomy in this setting is an over-treatment for a lot of patients, probably around 70%. However, some patients are difficult to manage and they don't have the availability to get the intravesical treatments. So that is something to think about also when discussing. The devices, intravesical therapies are also available. You can warm your bladder through HIVEC, hyperthermic intravesical chemotherapy, or you can warm it through radiofrequency. Both have shown interesting results, at least some feasible, if you don't have availability of other options compared to BCG when there is BCG shortage. But as you can see, the numbers are small. And but it's an option to offer to our patients if available at your center. I have no experience personally, but last but not least is our new option, that is immunotherapy. You may have heard it was presented at AUA this year, early on in May. So CREST study is immunotherapy, subcutaneous in this case. And in this trial, what they aim to look at is compare the addition of BCG induction plus maintenance, that would be our standard pathway, versus the adding an immunotherapy to the picture. The primary endpoint is event-free survival. As I mentioned, is a composite of the 3 recurrence, progression, persistence of CIS, and death from any cause. This is the composite of event-free survival. In total, over 500 patients were randomized. I think, yeah, 350 each arm, so close to 600 in each arm. And what we saw is that at 36 months, the event-free survival, it was much better for the combination, 82%, versus the BCG induction plus maintenance at 75% event-free survival. They also saw another interesting thing, that is the patients that had CIS and they had a continuous complete response. It was around 92% event-free survival for the combination versus 68% on the BCG induction plus maintenance. Obviously, the arm with only induction, as we said before, is not good enough. We know we need to add maintenance because it does not improve the outcomes if you only do induction. Overall survival results are still not reliable because it's a short follow-up, and these patients still need to be followed further. And they also did not show any differences in quality of life. There are some caveats to this trial. Just wanted to quickly describe, as I said, there is a composite of event-free survival. So whatever becomes part of this EFS is very important. So far, they have reported mostly high-grade recurrences and maybe progressive disease in 5 to 6% of the patients. We will have to see how this evolves over time. The other thing is that the overall survival data is still immature. We need longer follow-up. Then the other thing is that I think this is an open label design, so sometimes urologists will tend to be more proactive at finding recurrences. And also it's a very highly selected BCG naive population. Why do I say that? Because if we look at the rates of the biomarker of PD-L1, that is not predictive in this case, is supposed to be 20% in a high PD-L1 expression, which is interesting because high PD-L1 is supposed to be associated with poorer outcomes. So probably we are playing with a good outcome, a good players biologically in this trial. Maintenance also regimens differs from what happens in the real world, so accepting it in the real world might be challenging. And also side effects are an issue of concern in this setting. For me so far, patient selection will be an issue. We will need to identify a subgroup of patients that actually benefits the most and can handle the side effects associated with this in this IV treatment. Systemic treatment, because in this case it's sub-Q. And we also have to manage the potential long-term side effects of these treatments in healthy population otherwise. There are other trials that will come out in a similar setting. Potomac Alban are also similar to CREST in terms of how they are designed. The Pembro trial, the Keynote 676, is a little different because it also has an arm about reducing maintenance in this context of boosting with immunotherapy. Also, the follow-ups are a little different, and while we see that CREST, also the number of cycles is up to 2 years. And basically, the endpoints are very similar, even though the definitions, as I told you, they include mostly a composite of different components. And we're looking forward to these results. And thank you.
Thank you, Carmen. Excellent presentation. We will discuss also about this during the final session regarding question and answer. Just a reminder, so feel free to ask a question in the chat, then we will try to discuss at the end. So now is the turn of Francesco Soria that will discuss what will change in the next 5 years for non-muscle-invasive bladder cancer.
Thank you. Thank you, Marco, for the kind introduction. It's a pleasure for me to be here. And also thank you to Laura and Carmen, because they did a good job and also already talked about something I will discuss later. So half job is already done. So thanks for this. And these are my conflicts. And of course, when talking about the future of non-muscle invasive bladder cancer, I think we have to struggle with 3 different ways. One will be probably the intensification, de-escalation for low risk and intermediate low risk disease. On the other side, we will face intensification of treatment, as we already saw now with Carmen, for high and intermediate high risk disease. And of course, we have the bladder sparing approaches for BCG unresponsive. That is the one that already encounter the biggest development in non-muscle invasive bladder cancer. So regarding the de-escalation in low and intermediate low risk disease, as Laura showed us, disease progression in low risk disease is almost 0% at 5 years, and more or less is also the same for those patients belonging to the intermediate risk with the lowest risk of disease progression. So basically the patients without risk factors, and these patients share more or less the same profile progression risk of the low risk patients. So these are the ideal candidates for the intensification. As Laura said, EU guidelines already contemplate the office-based fulguration, active surveillance, chemoablation, and they already recommend to use, for example, office fulguration in TA low-grade recurrent tumor with a strong recommendation, and active surveillance or chemoablation with a weak recommendation in these patients. But what about the future? Well, actually, probably chemoablation is the most interesting setting. Chemoablation has already been studied in 3 randomized trials with mitomycin given intensively preoperatively, so instead of QRB. And the most recent was the DABLA-CA13 trial with 6 instillations of mitomycin in 2 weeks, with a complete response rate of 57% at 3 months, so at the first follow-up cystoscopy. But what is even more interesting are the trials that have been conducted using the so-called mitogen, so the UGN-102. And the most recent is the ENVISION trial, in which 240 patients with recurrent low-grade intermediate risk disease were treated with mitogel instillation, and complete response at 3 months was 80%, and 82% of responders, so 82, the vast majority of responders remain in response up to 12 months. So these are really interesting data, and this can be probably a game changer for the future, pending, of course, the problem of the cost related to this treatment. And on the other side, in high risk and intermediate high risk disease, we will have an intensification of treatment, so a totally different paradigm. Carmen already showed us the CREST trial, so I will go really fast on this. CREST trial presented at AUA, first study showing a new treatment for BCG naive population. And what is interesting is, of course, the numbers regarding the recurrence, the high-grade recurrence, because these are basically BCG unresponsive, and the new treatment will probably avoid BCG unresponsive up to 50% of cases. So actually the results were 7% of high-grade disease in the treatment arm and 15% in the control arm that was BCG induction plus maintenance. And of course, as already said, POTOMAC trial has the same study design. The results will be presented at ESMO into 2 weeks, but we already know from a press release by AstraZeneca that the treatment arm, that is durvalumab plus BCG induction and maintenance, will be superior compared to BCG induction and maintenance alone. So probably the same way and the same results of the CREST trial, but we'll look at the details at ESMO. We don't have actually data regarding the ALBAN trial with atezolizumab, but the design of the trial will be the same. So combination is probably here to stay, because probably we will have solid data from different trials. But of course, what is most interesting is probably the bladder sparing approaches for the BCG unresponsive setting. This is the pipeline of the approved, FDA-approved treatment for BCG unresponsive. So we face almost no changes since BCG, used for the first time by Antonio Morales in the 70s, until pembrolizumab. So with the keynote 057 in 2020, Pembro was the first new drug approved for CIS BCG unresponsive patients. And after Pembro, we saw the advent of the first gene therapy in bladder cancer. It is nidarofaragene firadenovec. After that, the interleukin 15 plus BCG, so the Anktiva, and very recently also the TAR-200, the gemcitabine intravesical delivery system from J&J, received the FDA approval for CIS BCG unresponsive disease. But these are only the FDA approved, but many other treatments are under investigation. For example, the TAR-210 in FGFR mutated BCG unresponsive patients, the combination of gemdose, the cretostimogene, we will discuss later about this. And also there is a trial ongoing about intravesical ADC, so with AV in the AV104 trial. And what is really interesting and important to me is the fact that the vast majority of this treatment outside in the systemic Pembro are all intravesical treatment. So as urologists, we have to know this type of treatment, because this treatment will come in the next future. And if you live in US, probably you can already use some of them. Regarding intravesical delivery system, the TAR-200, as already said, was recently approved by FDA for CIS BCG unresponsive disease. It reached a complete response rate of almost 79% at 3 months, with a median duration of response that is 26, 27 months, so more or less 2 years. So really interesting data. And making a step back, we have to say that intravesical delivery systems won't be used only for BCG unresponsive disease, but are also currently being tested in intermediate risk disease with the TAR-210. TAR-210 releases erdafitinib, that is an anti-FGFR in FGFR intermediate risk with upregulation of this receptor. And this is, of course, another way to intensification of treatment in intermediate risk. But probably what will change the paradigm of the treatment of BCG unresponsive, and not only, will be and is already probably the gene therapy. And I have highlighted all the trials that have been completed or are ongoing in BCG unresponsive, BCG naive, and intermediate risk. And these are all trials with gene therapy. So gene therapy is coming all over the spectrum of non-muscle-invasive bladder cancer. And nadofaragene was the first gene therapy approved for bladder cancer. In the first trial, CIS BCG unresponsive patients, complete response was achieved in 53% of the patients, with a median duration of response of about 10 months. This was the registration trial about nadofaragene in CIS BCG unresponsive patients. But since nadofaragene is approved since 3 years, more or less, we have already also first real-world outcomes of patients treated with nadofaragene feradenovec. And actually, in real-world, data are even better, with a complete response of almost 80%. And if you look to this data, is more or less similar to those achieved from the Sunrise-1 trial, and with a really good duration of response. But nadofaragene is also being studied not only alone, but in combination, again in BCG-unresponsive CIS patients. In this the ABLE-22 study, nadofaragene is studied in combination with gemdose or with pembrolizumab. And we've already also studied in intermediate risk disease in ABLE-32 trial, in which patients with intermediate risk non-muscle-invasive bladder cancer based on AUA criteria receive TURB, and then will be randomized to either observation or intravesical nadofaragene. Primary endpoint will be recurrence-free survival. So you see how gene therapy is coming from the BCG unresponsive to the BCG naive to the intermediate risk disease setting. But this is not only not the only gene therapy. We have also the cretostimogene. Cretostimogene is another adenovirus. In this case, it allows oncolytic immunotherapy with directly tumor lysis and stimulation of immune response, is administered intravesically. And in the BOND 003 trial, the cohort C was again in BCG unresponsive CIS patients. And in this trial, complete response was achieved in 75%. So again, more or less between 75 and 80% of response at 3 months is what we already have with these new treatments. And what is even again important, like more or less the nadofaragene, and not so differently from the Sunrise, is the very good tolerability profile that led to a fast-track designation from the FDA. So in conclusion, what we know is that for low risk and intermediate risk, low non-muscle-invasive bladder cancer, we will probably have to face chemoablation, with mitomycin gel being probably the most attractive option. In high risk and intermediate high non-muscle-invasive bladder cancer, we will have combination therapies, intravesical delivery systems, and gene therapies. While for BCG unresponsive setting, of course, gene therapies will play a major role, intravesical delivery systems, and of course, we are very curious to see the first data from intravesical ADC. So regarding the future of non-muscle-invasive bladder cancer, I will say that the future is bright, but also that the future is now, and we have to be prepared. Thank you very much for the attention.
Thank you, Francesco. Excellent presentation. So I invite also Carmen and Laura to activate the webcam. And so we received several very interesting questions, and I would like now to go through some of these questions. And also, I would like to ask you to answer like in 10 seconds, because actually we do not have much time to spend much time on it. So for all of you, the first question is regarding the presentation of Laura. So regarding intermediate risk group, we all see that actually what is difficult in this group is to spot what are the worst patients and to divide the worst patient with the worst prognosis to the patient with actually a good prognosis. So the difficult part for me in intermediate risk is like this, to rightfully select the patient to give the proper treatment. My question for you is, do you use any biomarker for that? Or if not, if you think that there are no active biomarker right now, what classification do you use? EIU, AUA, NCN, IBCG? What are your expert opinion on that? So if you want to start, Laura, then Carmen, and then Francesco, very quickly.
Yeah, of course. If we look at the intermediate risk group, I usually use the EAU risk classification, just cytology to rule out high-grade disease during follow-up. But I mean, for intermediate risk, yeah, I would follow the EAU classification. I think chemotherapy adjuvant is a good option, provided that the patient can be followed. And then I would prefer to keep BCG, but also the side effect of BCG for a later stage. For example, if a patient recurs after intravesical chemotherapy, that is also what I said, in a high-grade intermediate risk tumor, I would be more inclined to use BCG sooner.
Okay, and then Carmen?
Okay, for me, I would use the IBCG because classification, because to me it's more clinically applicable, is easier to follow on a daily practice, and it talks about the spectrum that Laura was mentioning. So it's able to separate the patients in 3 groups, and it makes you more. It reassures you about using the BCG in the right patients. To me, mitomycin goes to the low risk, like easy ones, and whenever it comes back, and then it's telling you that there is something else, and it's going bad. So you should use the BCG then.
How long the BCG then, and also if it's also feasible to give mitomycin to some of these patients. Sorry, Francesco, go on.
No, I mean, I completely agree with Carmen. I usually use the substratification of intermediate risk. And what we have to say is that no matter how you use the IBCG classification of any grade is high risk, any high grade is high risk, or the EAU classification, at the end of the day, from a practical point of view, it doesn't make really a big difference, because usually for high grade, we go for BCG, and intermediate risk, probably for 1 year is enough if the patient is doing good maintenance for 1 year. Also, relying on the studies from the EORTC, we can just stay in 1 year for intermediate risk.
Okay, that's an important message. Then regarding the de-intensification, we got a question regarding the opportunity to do laser fulguration, but then also to do adjuvant maintenance of mitomycin after laser fulguration. What are you doing in your centers regarding the intensification? Are you also combining these two things? Because normally either you do laser ablation or you do chemo ablation, or you do active surveillance. What do you do, and do you mix these the intensification treatments in your patients? So I don't know if you, Francesco, you want to start, and then we can go back.
Well, this is an excellent question. Actually, we are offering office fulguration to intermediate risk patients. So usually these are patients who already recurred and that already probably received some kind of treatment, so at least single postoperative instillation. So when I do office fulguration, I usually also administer after that adjuvant instillation, because we are in intermediate risk setting, and also so to prevent recurrence. I think this makes sense.
So Carmen?
For me, I don't do it on my fulguration in my institution. I do active surveillance. I personally feel very comfortable with the patient understands it's a matter of counseling. If you counsel properly, they understand and they can do it. One question that always rises is if you should do cytology when you're doing these active surveillance protocols, because it comes out to the mind of some urologists. And it has shown that if you have proven that it's a low grade, and it's not worth doing the cytology when you do active surveillance, which is, I think, interesting.
I also do active surveillance, but also office fulguration. I think active surveillance, as Carmen says, is a good option. Sometimes I just want to avoid to have a patient back for another cystoscopy after 3 years, because I want to be completely sure, and then I decide to do office fulguration of a small recurrent low-grade tumor, just to be able to send the patient away for a longer period of time. But I think both are good options. I mean, it's It means quite a lot for a patient, I think, to avoid TURBT. So I think that can be beneficial and safe.
That's great. And so now we have also in this regard a very fresh question is the indication of second look. I will answer in the chat, but just very briefly, do you do second look TA high grade? This was always an open question. If you have a TA high grade, do you do a second look in your center or not?
No.
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 Okay, so very clear. And then let's change and go to the high risk. So high risk BCG naive, you presented the data of CREST. We know that Potomac and Alban will be presented at ESMO. What are your feeling about, considering that we are using BCG now for 40 years? And my personal feeling is probably it's time to improve somehow the treatment. And we need, of course, the results. But what is in your mind the necessary results that we need to get rid of BCG? So what do you want to see in this trial? Improved progression, good quality of life? Yeah, I don't know. What is your point of view? What do we need to beat BCG?
Well, I start. I think BCG is probably here to stay. I don't think we will get rid of BCG. BCG works. And also, if you think now in the BCG responsive setting, there are many ongoing trials with combination with BCG. So with BCG use also in the BCG responsive setting combination with other new treatments. So BCG is probably still active. And from these new combination treatments, I agree with you that probably we need to improve BCG. Again, is we always end our talk saying that the key is the patient selection, huh? And this is even more true for the combination therapies. There are probably some subpopulation that will benefit from these combination therapies. I'm thinking about probably some CIS patients from the first results of the CREST trial, but we have to see the final results, and also from the Potomac trial. It will be probably impossible to give the combination to all the patients, and also we have to think that we are in a non-muscle invasive setting, and also adverse events play a major role.
So I think a little differently than Francesco, to be honest. I look at BCG like we used to look at ADT. So I think there will be an evolution. Like now we have evolved into thinking, okay, maybe ADT is not enough. It's with enzalutamide or wherever we have, it's much better. It is enough. So I think with BCG we will have the same progress. And once we figure out the mechanism why it works, why it triggers the immune system and what's going on, then we will evolve over it. And that's what I think, but we are not there yet, definitely. Still BCG is our primary treatment.
Yeah, just a different perspective. I mean, knowing that many patients do not complete 3 years of BCG, not even 1 year of BCG. Another advantage of a combination could be to be able to shorten the overall duration of treatment.
That's great, excellent point. So the last final questions for you is regarding BCG responsive options. So of course, we do have all these options with the idea, the possibility to spare radical cystectomy to our patients. What do you think now regarding this option, these ongoing trials? Do you think that if you have this trial, would you offer this option to your patients, and would you consider, or if you don't have the trials, to move to other center to spare radical cystectomy to this patient? What do you think?
Yes, short answer.
Yes, we'd send to another center if they can spare their bladder. Nobody wants to get their bladder out unless they are very unhappy with their bladder, which is uncommon.
No, I agree. If you don't have the clinical trial, just refer the patient. And we have also data showing us that if you do a sort of a one salvage treatment for BCG unresponsive, you don't lose the window for radical cystectomy afterwards. So I think it's worth to try a bladder sparing approach, at least one.
Yeah, that's very true. All the data that you show are very appealing. We need definitely more mature results, but actually the future is bright for the disease. So thank you. I want to thank you all for the excellent presentation and for the nice discussion. And I also would like to thank all the participants for being here this afternoon. Thank you very much.
Thank you, Marco. Bye.
Thank you.
Thank you.